M&E in CASA control tools that we use in a CASA control program. We have two panelists who are going to be with us this afternoon to take us through this. My name is Anne Getungo. I'm a health information specialist. I've worked in the Ministry of Health for the last 38 years, and I'm going to be the moderator of the day. Our first panelist will be Luce Mwangi. Luce Mwangi is a health information officer who has worked in the ministry for quite some time, for more than 20 years. She has worked in Kejabi Mission Hospital. She has also worked in Kajiado, Akagudo Referral Hospital, and Madari Teaching and Referral Hospital. And right now she's working at the Ministry of Health headquarters in the Division of Health Informatics. She'll be our first panelist who is going to take us through the cancer treatment tools that we use in the ministry to collect the cancer information, the cancer data that we usually use. You know, M&E is quite, is very important in any monitoring any program. And these tools are quite key because they give us information on the current threats of the cervical cancer data that we have in the country. And they really help us in planning on the issues that we need to do in decision making and making other planning that needs to be done in the Ministry of Health. So welcome, Luce, to take us through the M&E tools that we use in the ministry. Thank you, everybody. You have a plenary section at the end of the presentation of the two panelists. So in case you have a question, you just put it in the chat. We address this at the end when we are doing the plenary. Thank you and welcome, everybody. You can stop. You can stop sharing the screen so that Lucy can do the sharing.
Hello, everybody. Thank you for joining this call. It's good to have you here. And Anne has already taken us through a bit of introduction. We all know that cancer is a great burden to our country and even globally. And we are here to understand the tools that we can use to help us collect data using the collect data element so that we are able to monitor and see how well we can plan for our healthcare service delivery. We can also see the tools will also help us to see the gaps that are in there, and in return, will we be able to manage our healthcare even as it is well desired. Cancer, it's a great burden in our society, that is in our country and even globally. And we know it is the third leading cause of death in this country from infectious diseases and cardiovascular diseases. And a report that was done in 2018 by International Agency for Research in Cancer indicated an increase incidents, the new cases, that is the incidents, they were ranging at 47,887 with a mortality of 32,987. That is a very, very great burden. And we can only be able to help out this situation when we have good and correct data correction tools that will help guide us and will be able, in return, to be able to see the way forward. And we are going to go through our presentation of the day, which is going to guide us. We are guided by the Kenya Health Sector Strategic Plan, which provides the overall framework for health sector policy direction. And these tools have been made, or they have been prepared, guided by the KHSSP. We have a number of documents, again, that we had to refer to, that is operationalization through the following documents: Kenya Health Policy Framework 2018 to 2030. And we also have the Kenya Health Act 2017. We have Kenya Essential Health Package for Health that gives us the from the primary level of care, health sector partnership and framework. Basically, these are the guiding documents that has helped us through. And we have the process of the revision of tools, that is development of health sector indicator manual, that is the third edition. It is guiding us to know the indicators that we are able to track. And with the revision of tools, we have the primary data correction tools, the MOH 412 and the MOH 273. Those are the primary tools that we have in correction of cancer data. The MOH 412 is these are, and the 273, these are screening. They help us to screen the healthy population. And when we screen the health population, we can make conclusions, and we are able to tell the already who turned positive on how they can go on with the treatment. We have the revision of health sector reporting tools. Those are our summary tools. They help us summarize data at the end of the month. The MOH 412 and MOH 273 are our daily activity registers. But when we come to the end of the month, we need to summarize and report the same. And then we are able to upload this one in the Kenya Health Information System, which is the platform that we all use to report data within the country. And from this platform, we are able to make reports, we are able to draw conclusions, and even be able to analyze data as per the need. We'll then have the printing of the final revised tool. After we have all the tools intact, then we can print them and ready for distribution of the revised tools to the county up to the health facility level. That is done by from the program, and the dissemination during dissemination, we do also sensitization. So in case there was some new data elements that were incorporated in the new tools, the people who are at the health worker at the service delivery points, they are made aware so that it's not a new thing to them. They know at every day there is what they are reporting on, and all the data elements are well understood by the care providers. That is also in form of training of the health workers, so that they're able to understand the tool they are working on and they are working with. And at the end of the day, they are able to capture data, and so that we have the element of completeness to avoid the gaps that brings challenge while we are reporting. We now have also the use of revised tool in data collection at the health facility. After the training, the tool can start working, and also we monitor by the help of Kenya Health sector strategic plan and the UHC indicators. This is our guiding. The UHC is universal health coverage. This is what guiding us as we monitor progress and see whether we are able to capture data as it is required. There before we had tools that we were using previously, that is cancer screening register MOH 262 and cancer screening monthly summary. That was an integrated to them. The current MOH was incorporated the cancer data. But from August last year, we started now using fully the new tools that were created from the program. And from the new tools that were revised, we have cancer screening register, the MOH 412, cancer screening, a monthly summary form. These are as I said earlier, they are tools that are used in a healthy population. And once we screen people for breast cancer, we screen for cervical cancer, we screen for colorectal, we use these particular registers. Once we realize that there is need for further management, for further investigation, we send them to the treatment centers where they can now be entered into cancer treatment register. There is more diagnosis, further diagnosis can be made. And at the end of the month, we are able to summarize this data and we upload it in the KHIS. This data in KHIS is supposed to be uploaded by 15th of every month. And we also have the cancer treatment commodity register, that is MOH 646. This will help in recording all the medication that are being used by the patients, the clients who are positive. And we are going to see each and every format of each and every register, as I have discussed, and the summary forms. From the screen, you can see we have MOH 412. That is our cancer screening register cover. That is the cover page. It is purple, light purple in color. We have the MOH register definition. This is the instruction page. From this page, it's actually the first page when you open the register. It gives you the instructions on how you're going to go ahead, and it also gives you the elements and direction on each and every column, each and every row, how you're going to fill and what you're going to fill in that particular law or column. Remember some of these from the instruction, we can see a number of elements are coded. So to the light. Each patient is supposed to be in one particular law. Then down here, we have a page summary. A page summary is not a daily activity. It might be a daily activity if you were able to fill this particular page, just in case you had many clients. But in the event that the patients were not as many as per the number of rows in this particular page, you can continue tomorrow or any other day. And then from there, when the whole page is full, then you can continue and do your page summary. Page summary helps us to report progress as we continue with the delivery of care, and it also helps simplifies when we are doing our monthly summaries. You just come to the page summary and you're able to pick up the data that you had already summarized. It actually makes your work easier. We have cancer screening summary. This is a summary form that is usually in a register. At the end of the month, you plug, and you're able to report what was now on that how you have been seeing your patients from the time you started for the whole that particular month. Here is the sample of a cervical cancer summary. This is part of it. Is actually taking the 3 parts. We have the cancer bit of it. We have the breast part of cervical cancer part of it. We have the breast, and you have the colorectal. This is the cancer screening monthly summary form, and we have the breast cancer summary form here with us, and also the colorectal cancer summary form. So at the end of the month, you are able to summarize your data. Remember those people who turned positive, or maybe you wanted them to go for further diagnosis, you send them to the treatment centers, and once they come to the treatment center, they are entered into this particular register, which is MOH 273. And here is the cover of the MOH. We call it Cancer Treatment Register. We have the MOH 273. This is our page of definitions. It gives you an instructions on how you're going to go by when you're filling your register. So you don't have to, this page is very key. It will guide you. You don't have to struggle when you're filling the register, or it also gives you a form of uniformity when you're working with your colleagues. So when you are working and another person comes, you just continue with the same thing. It brings an element of commonalism. And we have MOH 273. That is how the register looks like. That is page, maybe it can be page 1 on page whatever. We said again, you fill all the records up to the last row, and then you can do your page summaries. Here you go. It's this is the first part of it. The register is quite big, so this is a continuation on the same. We have MOH 746. This is the cancer care and treatment monthly summary form. Once you fill your 273, this is where you summarize at the end of every month, so that you are able, you make it your data. It is going to be more easily. It is like being summarized, and you can easily be able to capture in some data elements. And once you know, you can be able to get to tell like how many treatment method that were provided, how many people were treated using, how many people underwent for surgery, how many people went for chemo. It summarizes your data at the end of the month. We again have the MOH 646 summary cover. This is the cancer facility consumption data and request tool. This is the one that tells you how you have been consuming your commodities within each and every facility. Yeah, you summarize it. This is our instruction page where you get on how to fill it. We have this reporting tool will be filled by a person responsible for aggregating cancer drugs for the entire facility as designed by the facility in charge. Remember, there are a number of variables that you're supposed to collect. The person reporting should clarify the number of cancer drugs dispensing points in the facility before filling the tool. Remember, a facility can be having different dispensing points, and also for the delivery of care, the service delivery points can be different. So remember, once you are doing your summary at the end of the month, it's always good to incorporate all those data from different delivery points. The report should be uploaded into DHIS by 15th of every month. This is the requirement by the Ministry of Health, that all the health data should be uploaded, to be summarized and uploaded by 15th of every month. And the reporting period is the most recent calendar month. That is the following month, not the particular month that you are reporting. and you're supposed to report data from the whole month, that is the previous month. Facility name, these are some of the variables. Like the name of your health facility. We have the MFL code, like the master facility list of your health facility. Remember, each and every facility has a unique code. It should be noted. The period of reporting, that is the beginning. When you're opening this form, you have your beginning and also the ending. We have the beginning balance. Remember also to include losses and wastage, positive adjustments and negative adjustments, and also the end of month physical. That is at the end of the month, what actually did you have? I remember always end of the month physical count will also go to the new beginning balance of the following month. That is the MOH 646, our commodity summary tool. Yeah, basically those are the tools that we have, and the process, we have the process on where we are going to capture data, daily activity registers, as I had already discussed, they are MOH 412 and MOH 273 are stationed at specific delivery points designated by the health facility. Remember, when you are doing your summary, all those, a facility can have like 2 service delivery points. So when you're doing your summary, it's always going to consider, and so that you can put all these data together. The nurse, stroke clinical officer, doctor in charge at a specific service delivery point is responsible for filling in the daily activity register and including the page summary. Always remember, after you have done with one page, do your page summary for easier capturing of the data in the end of the month. And point to know, it is important to always fill all the required variables. This is the element of completeness. Remember, when you don't complete all the data elements, it's like you did not capture everything. So once you're doing you're picking, you're collecting data, because when you are seeing patients, you're collecting data. Remember, all the variables are very, very important because they bring up an element of completeness, which is very key in data quality issues, so that we are able to get a whole, if there is the histology you are reporting, if it is chemotherapy treatments you are reporting, with surgeries you are reporting, it's always good to report each and everything so that we are able to have the representative data that is going to help in evidence-based decision making. We have our monthly summary here, which are done at the end of every month. And we said this one data should be fed and uploaded in the KHS by 15th of every month. If the facilities with no HLIO, the summaries are taken to the sub-county HLIO for uploading in KHIS. Remember, we have facilities that they are not able to, the HLIOs are not available, or they are not able for one reason or the other, they are not able to access the KHIS. This data is taken to the sub-county HRI, who is a health records and information officer, so he or she can be able to upload these data. Facilities should always submit reports to the sub-county on or before 5th of the following month. Once a month is over, the people working in that particular facility, they should be able to compile their data and they provide it by 5th of every month to the sub-county health records and information officer, so that now at the county level, sub-county level, remember this officer has a number of so many facilities like yours that were not able to upload this data. So it's always good, and it's the recommended time to deliver this data to him or her so that he can be able to compile it and also upload it by 15th of the following month. So that, and we are able to, by 15th of every month, we have all data uploaded in KHIS, and at the national office, we are able to check on the gaps of the data. Once it is all uploaded, we are able to tell which places that we had more data than required. We are able to, like, we are following this county or this particular this particular per county, we follow per county. We are able to tell this particular county has been reporting a number of cancer cases. Like, let's say they have been reporting like 500 cases per month, but this particular month they reported like 2,000 or 3,000. From the national office would want to know what actually happened to this particular county, and we are able to go through the system and understand what happened. Was there an outreach? Was there an error? And we are able to drill down and get to the facility that actually reported more, and there we can be able to know, is there data gap, data quality issues, and if then there are errors that were there, they can always be amended from the facility. At the national office, we are not able to make any amendments. It can only be done after drilling down to the particular facility that actually reported more or less. Remember, outliers can be extreme high or extreme low, and we are able to know what actually happened, follow up and know what actually happened at that particular facility. What is the importance of data? Data help us identify problems. Like when we report many particular cases in particular regions, we are able to identify and do some interventions when we realize in this particular region, we are reporting high cases of breast cancers. And then we can be able to see what is actually happening to people in that particular region. And we can do maybe health education on ways of living, because we have already identified there is a problem, because data actually brings out and points out there is an issue that is happening that is out of the norm. We also use this data for resource mobilization, and that's why we want timelines, so that when we are working with the data, we are able to work with something that is we have at hand to be able to mobilize resources and attend to those particular gaps or challenges that are affecting our populations. This data can also be used for operational research to help us research more on the ground, what can be done with the treatment method. Are they working? And are we able, do you want to know more about our population in each and every particular field? Logistic management, they help us to manage healthcare. Also, strategic planning. In the healthcare, we don't just plan, but we are helped by data to know our areas of interest, so that we know where to supply what, and know where not to supply what, like drugs, the healthcare workers. We would want to know which regions that need more healthcare workers, and others, yeah, like that. We are able to plan strategically. We are able also to measure impact and make informed decision, because with the data, you're able to know like where to channel your resources and what interventions that are required in healthcare. We have data correction and reporting gaps. We lack tools. It is that, but remember, changing that we have need they may be inadequate to reach to all our centers, and we have the centers for our health facilities that not, they have data but they are not reporting, and to make the decision, the data is coming in late. So as data is not them, we know our staff, our staff are in our main resource in when you are collecting data, and also we lack capacity. That is the people who are working on the ground, they really need to be trained so that they can be able to know the cases that they are handling on daily basis. we have no data reviews. Like we need to have data review meetings so that we can be able to check on our data. That is going to help us identify more gaps and areas of interest. Also, our lack of ownership. We have some common data problems. We have incorrect grouping of data. Data is incorrect refill, like when I was telling you about the completeness of data. When data is not properly filled, like some elements are missing, and at the end of the day, when you are doing your summaries, you realize there are so many gaps. It's always very important to make sure all the fields are properly filled. We also miss data, like when the reports are there, we report late or we fail to report. That's another mega. Also, double counting of clients. That is double duplication of data, and also for the commodities, which can bring issues when we are coming to plan. We may be planning more, or we may be planning for less. So these are some of the gaps. And we also lack accountability. The people responsible, we don't have responsible people, that ownership of data. And we also have weak system and processes. Yes, that's our system. Like now, we are digitals, the system are weak. By the time we get there, we realize it can be a major gap in our healthcare system. There are a number of ways that can help improve data correction and report. We have and training of health, and ensure that reporting on KHIS is done by 15th day of the following month, which is going to help us to check outliers I was telling about, identify more data gaps, and also use this data making reports, which can be done after the required. We also need to conduct regular facility data review. Can be before we report in the KHIS. It is always good to check that the data, like this officer, when they finish with the data, it's always good to check for somebody to check for you. It is actually what you in that particular month. And also you can sit down and do some review on your data to make sure that what you are reporting is actually true. This will also guide. We will not need to do so much on survey unless we want to research on some issues. It is going to minimize every other time when we are doing our DQA. We will not have to do so many data quality audit every now and then, because we are actually reporting what is there on the cloud. In data management, teamwork is the key. We need to work as a team. It is not one person business, but when we work together, when you finish your the end of the month, the person who is doing the summary does the summary, and then you do data review just before you report to the KHS. That is good teamwork. When we are into each part, we know that this is actually the service data that are provided. We have we have our summaries, and your role as a health worker. Accurate and timely data capture is the proper MOH data in the proper MOH data tool. Always ensure that what you are reporting is accurate and you have reported in the right timelines. Know your targets and track progress as you work towards achieving them. Yeah, you'll be guided by a number of indicators. It's always good to refer to them and see that you are on the right track. Consume and utilize data in clinical decision making. Data is very, very key, and we should always look forward to use it to make decisions that are going to be helpful in our healthcare setup. Thank you very much. All this information. Thank you.
Thank you. Thank you so much, Lucy, for taking us through that good presentation. We have been able to see the tools that we use in cancer data reporting, especially in the screening and treatment side. I want to let you know that we have a global call that Kenya is also a signatory, that we are supposed to screen 90% of our women and also have 70% of them. No, we have 90% of our girls 10 to 15 years vaccinated using HPV vaccine, and we need to have 70% of our women screened through the various methods that we have in the ministry. And after screening, we make sure that we link 90% as a minimum to treatment and care so that we can lower the burden of cancer in our country. So thank you so much for taking us through those tools. And it's good that all the variables that she has taken us through, we need to fill in all those variables because they are key in decision making in each level of service delivery, point up to the national level. What she has taken you through is in the Virtual Academy in the Ministry of Health. You can get all those materials there. And what you need to do is just register. She's going to show you how you register, and you can do the courses there, and you are going to get a certificate for the same. So please, Lucy, you can take them through. Okay, so you can just go to the ministry website, go to Virtual Academy, Ministry of Health, you register yourself, go to non-communicable diseases. When you look for the courses, in the non-communicable diseases, you go to cancer courses, and then you can choose M&E module. There are 5 modules that you can go through, and at the end you're going to get a certificate. So I encourage each one of us in this forum to enroll in that Virtual Academy, and you'll be able to get the certification after you are done. At this juncture, I want to welcome our second panelist, who is Gladys Chesumbai. Gladys is a Sub-Saharan African regional trainer, and she doubles as cancer registry coordinator in the Eldoret cancer registry. She has a wide knowledge. She has been there for the last 15 years, and she has been a team member of various scientific write-ups. She has done quite a number of publications, and she's going to share with us about cancer registration in Kenya. And I think all of us are going to benefit from her presentation. Thank you, Gladys, and welcome.
Thank you so much, Anne, for that very wonderful introduction. Welcome everyone for this presentation on cancer registration in Kenya. I think by now most of you already know that cancer is a problem in this country. And this is module 5 of cancer, of the modules that we have, and it is on cancer registration in the country. So we intend to equip you with the knowledge on basic practices of cancer registration. And this module will take you about an hour. The main objectives of this module are to define cancer registration. So by the end of this, you should be able to, define the cancer registry and cancer registration, know the importance of cancer registries, describe the types of cancer registries and the functions, Also to explain the guiding principles of cancer registration and the challenges that are experienced within the cancer registration profession. And also know your role in as health workers in cancer registration, and also be able to describe the cancer case abstraction process. So what is cancer registration? And what is cancer registry? Before that, we want to just maybe ask a question. You can be able to answer this on the chat box. So who gets cancer? Where is cancer found in our population? Which cancers are most common in your area? What is working in terms of treatment? What is the survival rate for cancers in your community? Can you get cancer? What is the stage of diagnosis for the cancer that you have seen in your area? So to answer this, we need to understand what cancer registry is, what cancer registration is. So a cancer registry is an information system that is designed for data collection, data storage, management, analysis, and dissemination of data on persons with cancer. We all work in our health facilities, and I hope from this module we can be able to look at cancer information differently so that this information can help us to make decisions. So what is cancer registration? So cancer registration is a systematic collection of data. It is a continuous collection of this data on cancer, occurrence, and characteristics of this cancer with the purpose of helping to assess and control the impact of cancer in a particular community. So cancer registration is continuous, it is systematic, and it is targeted to specific communities and specifically for cancer. So what is the importance of cancer registries? I would say that if you do not have a cancer registry where you are, it would be a good time to start thinking of how this can be done in order to provide information on the next steps. So importance of cancer registries. This helps in understanding the disease burden and to guide resource allocation. We know that cancer is a problem, so how do we allocate resources? How do we know that there are clusters? How do we know where to put resources? We need to have information and also a national system of cancer registries. Another importance of cancer registries is to collect accurate and complete cancer data that can be used for cancer research. Okay, different types of research. As yet, we do not know what causes specific cancers in specific people. So for now, we need accurate and complete data so that we can be able to find this out. Another importance is to inform public health programs and planning in terms of policy and clinical guidelines. So it is an information system, as we had mentioned, and it will help us in planning for policy making and guidelines, as well as patient care. Cancer registries also help us to determine the risk factors and high-risk behavior identification, as well as create awareness in the communities so that they can be aware of the risk factors and the risky behaviors that can lead to them getting cancers. You have seen materials on risk factors for specific cancers, and this helps to create awareness in our populations. Cancer registries also support lifetime follow-up of cancer patients. We are able to detect patterns and also provide information on survival of particular cancers. Different cancers have different survival rates. So cancer registries enable us to have this information, and this information in turn helps us to plan and to direct the correct resources and the correct amount of resources, help alleviate this burden. What are the types of cancer registries? We have 3 types of cancer registries. These are hospital-based cancer registries, population-based, and pathology-based. We're going to look at each and every one of these so that we are able to differentiate between what these are and what their uses are in our population or in our setups. The hospital-based cancer registry, which is in most of our health facilities, both public and private, are used to maintain data on patients that are diagnosed in that particular facility. So when a patient walks into the hospital, their data is collected, whether it is on paper form or electronic form, and it is kept in that hospital. And the purpose of this data that is collected is for clinical care and for hospital administrative decision-making. The hospital will use this data to determine the number of patients that have come into the hospital, which cancers are more prevalent, do they need to improve on the facilities, do they need more machines, do they need more personnel, do they need to expand their bed capacity? It helps the hospital to improve on the clinical care and to make decisions for the benefit of the patients who visit that particular hospital. The next type of cancer registry is a population-based cancer registry. And a population-based cancer registry collects all new cases in a defined population. Now, we are not talking about a hospital. We are talking about a defined population, and this can be a county or a sub-county or a region, a bigger region, let's say Nyanza region and such. So the difference here is the defined population, and this defined population must be defined by census, by the national boundaries. The population-based cancer registries emphasize on epidemiology and public health. So we want to look at each and every member of that particular population, that particular community, without considering the patients who just visit a particular hospital. Remember, for hospital-based cancer registries, a patient can decide to visit this particular hospital for their own reason or visit another one. So we would say that a hospital-based cancer registry would be a biased sample, especially for research purposes. So if we look at a defined population, we would be able to get all the people who are residents of that area, and these people would tell us something about the most common cancers in that population. That would tell us about their practices and what interventions can be done in order to improve the situation. Population-based cancer registries have special functions, and these are to determine cancer patterns among various populations, as I had mentioned, or subpopulations. We have a cancer registry for the population of Uasin Gishu. We have one for the population of Nairobi, another one, upcoming one for the population of Kisumu. Hopefully in the future. Therefore, we can be able to determine the patterns of cancers in this population because there are systematic cancer registration interventions. The cancer registries also that is population-based can be able to monitor the trends of cancers. Is this cancer going up or down? Do we have any other specific cancers that are coming out that were not there previously? It also guides planning and evaluation of cancer control efforts. So, for example, if we had screening being introduced 10 years ago, can we use a cancer registry to look at, for example, cancer of the as opposed to late stage and things like that. So we are able to guide planning and evaluation of cancer control efforts. It also helps us to prioritize health resources, as I had mentioned. If a certain population has more cancer of the cervix, then, or a particular cancer of the prostate, then more priority needs to be given to that population in terms of resource allocation and targeted resource allocation. Good for planning. It also good for advance to advance clinical and epidemiological and health service research. Most people would use the cancer registry for research, cancer registry data for research. So this data is usually available for researchers. If you're doing your master's, if you're doing a study, if you want to support information to support particular theories, you can be able to get this information as baseline data from the cancer registries. The other type of cancer registry is the pathology-based cancer registry. This you will find mostly in the histology labs where diagnosis is done. This can be private or public histology labs. Here you will find information on the histologies, the cytologies. You will also find immunohistochemistry. So pathology-based cancer registries support are a specific type of cancer registry that gives us a snapshot of the cancer profile. You will be able to see that a particular cancer is high or low or coming out more frequently, and therefore it gives us an indication of the problem areas within our communities. Although pathology-based data usually does not have adequate information, but for sure it gives us a snapshot of the cancer profile in our communities. This is a summary of the types of cancer registries and their purpose. And as I had mentioned, the population-based cancer registry will provide good information for cancer control programs and activities because it takes up, it focuses on the community. It is systematic and it has, it looks at a particular community, so it is unbiased. Because whether a patient will go outside the community for treatment organize and summarize this information on case notification form, and these forms will collect information on the names of the patient, their ages, demographics in general, information on the tumor that this patient has been diagnosed with, what kind of treatment they got, when was the date of last contact, which health facility did this patient go to, and was the last date of that we know they were alive, when was the last date, their date of death, if they're dead or deceased, was their death caused by cancer, what was the cause? Also within the cancer registry, there are standards of data collection, standards for coding, standards for reporting generally. And I would say that cancer registry is a global profession, and there are other cancer registries in the world that are supported under the WHO, and therefore what we do is supported by standards. There are standards for data collection, standards for coding, the ICCD, and standards for reporting, standards for analysis, and so on. We also report on incidence and mortality. And as I said, we also do survival rates for specific cancers. And this information is critical for cancer control and planning. As cancer registries also, we participate in cancer control programs, looking at the national cancer control strategies and supporting in terms of information for decision-making, both nationally and locally. So nationally, we have the guiding principles for cancer registration. And as most of you might have already heard, there's the National Cancer Control Cancer Prevention and Control Act, number 15, 2012, which states that notification of cancer is mandatory under this act, and there's a penalty attached to that. Most of our facilities are already reporting to the National Cancer Institute of Kenya, which is which states that the newly diagnosed cancers should be reported to NCI under the NACARE system within the 60 days of diagnosis. So most of us are already submitting this information to NCI. Are we submitting on time? Are we submitting accurately? Are we submitting completely? I think that needs to be looked at. Most importantly is that this information is important for decision making, and that because any of us can get cancer, then we need to have proper facilities around us that can be able to help us to beat this cancer menace. We also have the National Cancer Control Strategy for 2017-2022. We also have the most recent one, 2023-2027. And in there, we have recommendations for establishing of a unique patient identifier for the Kenyan population, and for enforcement of laws for notification of cancer. If we had the information reported, the cancer registries, as soon as a patient is diagnosed, I think this would improve on the reporting of cancer registries, because as it is, especially for population-based cancer registries, we have to go to the facilities and collect this information ourselves. That takes a long time. It takes a lot of effort. It requires a lot of resource allocation. But if the health facilities would completely and in a timely manner inform or submit this information, it would be easier, and I'm sure it would improve on the current status of cancer in the country. So in terms of the history of cancer registration in the country, we have had 3 population-based cancer registries. That is Eldoret Cancer Registry for the Western region, and that is the oldest cancer registry, which was established in the year 1999. And then
Sorry, Gladys, we have lost you. Hello, Gladys. Hello, Gladys.
Hi, Hannah. It seems that we may have lost Gladys due to some technical internet issues. So you can give it some time as she looks to join us, or maybe we can go through some of the questions that have been posted on the chat.
Yes, so I'll take you through the M-Saratani e-learning platform.
This just about
platform,
to be taken how we go through M-Saratani by Joseph Ngugi.
Okay. Yeah, my name is Joseph Ngugi, as you've been told, and I will take you through the M-Saratani e-learning platform. This platform allows you to go through material or courses that are specific to the cancer program. So for you to be able to access this platform, we have two, we allow access through Android as well as through iOS. And I want to share links to, I've shared some links on the chat, how you can access. So if you are using an Android phone, you'll go to the link that is that starts with the play.google. And if you're using an iPhone or an iPad, you can go to the link that starts with apps.apple.com. So those will allow you to download the application that I will be demonstrating. So to be able to access, once you've downloaded from the various stores, then you'll click on register. So when you click on register, you'll enter your first name, your last name, mobile number, email address, ID number. You'll select the county where you come from and the sub-county, the facility, and the cadre. So we'll also require you to enter your registration number. Then finally, we have the password, and you'll confirm your password so that you're sure that you've entered the right thing. So once you've registered, then you can be able to log in. So I'll log in using my credentials. So once you log in, you'll get information about the courses that are available. So we have introduction to cancer data monitoring and evaluation. we have basic chemosafe training, and we have cervical cancer course. Once you've gone through the material and you understand the course you want to take, so you'll continue to course. So here we have a list of courses, which is what we've just looked at. Then you can enroll for a course. So the ones that you have not enrolled, I've enrolled for 2 courses. That's why I have access course. And there are 2 courses that I have not enrolled. So I'll go to the early diagnosis of cancer for primary healthcare workers. So I'll click on access course. So here I have several modules. So I have overview of cancer, brain cancer, head and neck cancers, Kaposi, sarcoma, lung cancer, adult hematological cancers, and so on. So if I pick, say, brain cancer, I'll be able to go to a page that gives me learning material, access assessments. You can access forums, then live sessions, and resources. So if I go to learning material, I have the, say, one of the sessions. I can go through the course. So you go through the slides. The system remembers how far you had gone. So I think I'd gone through this before. So that's why. So you'll start from the first slide. So this is the first slide, and you can go through the material, and you navigate back and forth based on your pace. So the system also keeps track of your progress. So I think I've gone through this, so it shows 100%. And once you've gone through the material, then you'll be able to, there's a lock on the assessment. So once you've gone through 100% of the material, then you'll get the access to the assessment. So once you've finished and you've done your assessment, there is a 70% marks required for you to pass, but you have an opportunity to take the assessment 3 times. So so you go through all the material, and you can see the system keeps track of your progress. So if you come to, say, forums, okay, right now we don't have a forum, but if there is a forum created by the course manager, then you'll be able to respond to that. Then there are opportunities for you to take part in a live session. So the links would be shared on this section of the system. So then we have resources. Any resources that are available for you then would be available under resources. So once you go through the entire course, you get a certificate, and that certificate allows you to earn CPD points. So that's important, that you go through the entire course so that you can earn the required CPD courses, the points. Then if you have any questions, then we have an area on the system where we call consult. So here you're able to ask questions. So you can probably just ask a question, choose a module where you want to ask the question, then you type your question. This question will be sent to your course manager, and they will be able to respond to you accordingly. There are opportunities that we have to put once the response has been given by the course manager, they can also add that question if they find it useful to other learners. Then they will add it to the frequently asked questions. Then we have the calendar of events. So here there are various events that would be taking place involving the cancer program. Then they will be posted on that calendar of events. Then we have a tab that's called More. This allows you to change your password if you need to. Then you can also learn about the courses. Then you can download your certificate from here. The certificates that you've earned would be on that. Then you can also go through the terms and conditions as well as the frequently asked questions. Yes. So I think with that, unless we have questions that I can respond to. There's a question that asks, can you download on laptop or desktop? If you have a Mac, you can be able to download to your laptop. But if you have Windows, then you'll not be able to do that. I don't see.
There's another question concerning the Msaratani app by Mutisia Daniel, is asking if the app is only applicable to staff in the hospital-like facilities, or does it go beyond?
It goes beyond the staff in the hospital. There's a question from Raphael Koima about the pediatric oncology. I would need to look at that to see whether that is available, but I think it should be available. If it's not there, then it can be added. Okay, there's the question from Mutisia. I get your concern because the system is requiring you to enter a facility. Maybe that's something we can adjust to allow you to register without selecting a facility, or we add something like other. Yeah, that will be addressed. Thank you.
Thank you, Joseph. I don't see whether can see any other questions that have not been addressed. So thank you so much for that presentation. At least people know that can be able now to enroll in Msaratani and take the courses as you have just directed. Thank you so much.
You're welcome.
I don't know whether, thank you. Gladys, are you back?
Unfortunately, we haven't been able to get Gladys back on.
So I think it's also a good time to get Lucy taking us through with a few minutes remaining how to log into MOH Virtual Academy and see how you can enroll for the various courses that are enlisted there. So Lucy, please.
Thank you. Good to have you again. You go to your browser, the one you normally use in your computer or your phone, and then in your URL you type MOH Virtual Academy login. It will bring you to this particular window, and then from here you can see the Kenya Ministry of Health Virtual Academy. you select, and then it gets you to this particular dashboard. On your extreme light, if you are you already have logins credentials, you can say login, and it's telling you that you are not logged in. So if you have credentials, you click on login. I hope you're able to follow. On this case, because I already have credentials, I'm actually able to log in direct with my credentials. But if you don't have credentials, you choose new account. Then from new account, you're able to register yourself, and once you have your credentials, then you up to the end, you create my account. An account will be created. And then after the account is created, you can be able to log in, just as I'm going to do right now, because I already had my own account and my credentials are active. So you click on login after you have opened an account. It's opening. It gets you to another platform, and then here you have dashboards, calendar, badges, but we are interested on courses. This is for the people who want to know more about cancer. So you click on all courses. It gives you a highlight buttons over here. Then you select. Yeah, cancer is other non-communicable diseases. So you highlight non-communicable diseases. And then from here, you can select, you have drop down. Here you can select all the courses that you want. There are as many. You can learn about the KHIS, you can learn about, but here we are interested on non-communicable diseases. And here we have the cancer. It is going to give you, yeah, if you want to, it has some modules. We have module 1, overview of cancer. These are the modules that you can actually get. So that is how you learn. And then at the end of the training, you can get a certificate. So basically, that's how you get into MOH Virtual Academy, and you can now learn about a number of courses as directed by the Ministry of Health. Thank you.
Thank you again, Lucy, for that good presentation. We know where you can get materials. You can get materials to learn. They are available free of charge, and after that you get a certificate for the same. All cancer materials are there, from all the way from prevention, diagnosis, all the way to M&E. You can get all those materials there. So Gladys, you are back. Don't know whether Nelson, we have time for Gladys.
Of course, of course.
Hi, everyone. Thank you for being patient. I had some technical issues.
So can you hear me, Gladys?
Yes, yes, I can hear you. Can you hear me?
Hello.
Hello, I can hear you.
Yes, I can hear you now. You are left with quite a number of slides.
Yes.
In the interest of time, I think there are not many, so give it back to you to complete. Thank you.
So we'll proceed with the cancer registration. Thank you, Lucy, for taking up. As I try to share my screen, I hope if you have questions, you can type on the chat box so that we can answer them as we go along. Okay.
We are just seeing your desktop, Gladys. Okay.
Let me try and share again.
Okay.
And we have efforts that are ongoing to improve the quality and coverage of the national cancer registration in Kenya. So we look forward to expansion of the cancer registries. As some of you might already know, we are only covering about 5% of the population, and we hope in the coming days we are going to expand this cancer registry. What are the challenges of cancer registries? We have inaccurate incidence and survival estimates. When or where the cancer registry is not very well funded, and that there are no staff that are adequate for the specific population, you can find that there are inaccurate incidence and survival estimates being thrown around, and this is not good for cancer control efforts. In our health facilities, we find that there are lack of staging and ready information, or sometimes even information on the patient demographics. You find that instead of writing age, the correct age of or year of birth, we write adult for A and C for child, and that is very poor information, very poor documentation. In the death records, we also have inaccurate death records, and this can be based on poor reporting of deaths, especially on the informal reporting. And this also impacts on the accuracy of information on survival of the patient. We also have mobile populations. People move around a lot. They come from the actual homes, they go to the urban centers so that they can get care. And sometimes it is very difficult to follow these particular patients and pin them down to a particular population. The health system is fragmented, and this I'm sure all of you have noticed. Sometimes the patient really moves around a lot, and there is no unique identifier that can identify this patient even when they move to a different population. So the fragmentation of the health system is a very big challenge to us as the cancer registration personnel. Also, there's an inadequate number or a lack of cancer registration personnel. This particular cadre of staff is not part of the scheme of service of the national scheme of service, and this is a big challenge because health records and information personnel are needed in other areas, and there's a lot of transfers also that happen. So a specific cadre is not yet coined in terms of the cancer registration personnel. As I said, the role of health workers is to ensure complete and accurate documentation of patient information, and that we should regularly update information on the cancer medical record. We can also make sure that the information is accessible to cancer registrars, support the cancer registry staff to be able to abstract this information, even where you as the health records or healthcare so the cancer registrars are able to collect information, and this is good for everyone. The process of cancer abstraction is simple yet complicated. The cancer registry staff will go to the medical records and source documents to abstract information on the cancer patient. They are trained in a very specific manner to be able to get as much information on the life cycle of the cancer patient, and this is what they will do, as well as code this information using the ICDO. Information on the patient demographics and medical information is also gotten using the cancer registry tool. And as we had mentioned, the cancer registrars are trained and professionals who will be able to do this. We use the cancer registry abstraction or cancer registration notification form, and we capture information from the health facilities, and here we get information on patient details, tumor details, treatment information, comorbidities, and the patient status. Are they alive or are they deceased? On the health facility details, we get information on the facility name, the MFL code, what type of facility it is, who owns the facility, is it a private or a government facility, is it a county or sub-county facility, the licensing body of the facility, as well as the services provided by this particular facility. On the patient details, we get the name, the gender, race, ethnicity, place of birth, usual residence, telephone number, general demographics of the patient, so that we can differentiate between one patient and another. We also get information on ID numbers, specific identifiers for the patient, because without the identifier, we cannot tell if this patient is the same as the other one who has been diagnosed, who have the same name and probably come from the same area or residence. Tumor details that we collect are information on the primary site, the cell type of morphology, extent of disease, laterality, as well as grading, staging information, and the dates, date of incident, the date of diagnosis, so that we can tell the age at diagnosis and other information. We also collect information on treatment and information regarding treatment. For example, what did they get surgery? What type of surgery did they get? When did they get this? Is it radio? Is it chemotherapy, hormonal therapy, immunotherapy? Did they get palliative care? Some cancer registries also collect information on any traditional form of treatment that this patient might have gotten in the course of their diagnosis. We also want to know the dates of treatment. When did they get this information, this treatment? Some people also collect information on number of cycles of chemotherapy or radiotherapy. Information on comorbidities also is collected. This includes other illnesses apart from the cancer that has been diagnosed. And this could be HIV, it could be diabetes, and any other high blood pressure, depending on the cancer registry objectives. This section usually ensures integrated care for the patient to optimize the outcome for this patient and minimize any adverse effects. On the patient status, we collect information on when we last saw them, date of last follow-up, were they alive, as I said earlier, are they deceased, when was the date of disease, of death, for example, on the date of last contact. It helps us to record information on patient survival. We can be able to analyze survival, we can also be able to analyze the prevalence of the disease. This is a snapshot of the cancer abstraction form that is used by the National Cancer Institute for the NACARE system. Most of you might have seen it, but it has the information I was talking about, the facility details, the patient details, their names, the ID number, passport number, birth certificate if they're children, and all this information on their religion, level of education, and things like that. We also have information on, you can see my cursor, the place of diagnosis, date of diagnosis, the type of cancer, how were they diagnosed, what is the extent of disease or the stage of diagnosis. If they received, if they were referred from somewhere else, we need that information to be documented. Treatment information as well, what they received, if they have any comorbidities like cardiovascular disease, renal disease, sickle cell disease, any autoimmune disease, we document that as well. And also their follow-up information, whether they're alive or deceased, among other things. So we get this information from the admission sheets, the autopsy records, consultation reports. All of us here document this information. They document this information differently. Most of us can put this information down at different levels of the patient. And this can be from the diagnostic radiology reports, discharge summaries, doctor's reports, endoscopy reports. We are all responsible at different levels. So let us be able to document this accurately in a timely manner so that it can be available for the cancer registry. Also in the labs, we have the hematology reports, the laboratory reports, can be the histology, immunohistochemistry, cytology reports, any medical data sheets, medication records, nuclear medicine, imaging scans. These are source documents for the cancer registry. Among other things, also referral letters. So what is the take-home message for us today? The take-home message, the key message here is that cancer registry is an information system that is supportive for cancer control and information, and that this information system can collect, store, manage, and analyze data for cancer. And the other take-home message is that cancer registration is a continuous process. It is a systematic process, and it is for documenting the occurrence and characteristics of cancer and other reportable malignancies, and that all healthcare workers can support the cancer registration process by ensuring complete documentation of cancer on the cancer in the medical reports. So let us all support the cancer registry. This information is available on these sites here. And we have a population, a procedure manual for cancer registries in sub-Saharan Africa. We have also gotten information from these references here that you can be able to access as well. Thank you very much for paying attention. Thank you for your time. This is the end of this module. Congratulations for taking part in it. Back to you, Anna Gitungo. Thank you very much for moderating this.
Thank you so much, Gladys, for that elaboration about cancer registries and how they work. You have really taken us through, and we have understood what we need to learn about cancer registries. And I think, as I told members at the time we were starting, she is a great resource to Kenya, and we can really make use of her. So I think we have gone beyond time. We were supposed to finish our meeting by 3:30. and it's almost going to 4. And we have tried to answer quite a number of questions that you have posted in the chat. There are some that we don't have answers at now, but you look for answers and return. So I want to take this opportunity to thank each one of us for attending this virtual or running meeting. We will continue having such, and you can learn from our virtual academy, M-Saratani. Those are running platforms that all health workers can use to engage with. And as we told you, you are going to get a certification after you are done with all modules. They will enlighten you more as you also do your daily work in taking care of the Kenyan citizen that we look after. So thank you so much, our panelists, do say. Gladys, and also Joseph Ngoge, who took us through, and also Nelson for also moderating as well. We are quite a number of us, and we were able to communicate well. So thank you so much, and God bless us all. Thank you.
Thank you as well, Hannah, and MOH NCCP team. We were glad to have you for today's session, and we're looking forward to the next ones that are coming up. My name is Nelson, and on behalf of KNH Research, we would like to also to thank you for joining us today. We will be resuming our sessions next week with the clinical ethics series on Tuesday, and also we'll be beginning mental health suicide prevention sessions starting Wednesday next week. So kindly be on the lookout on your emails for the notifications so that you can be able to join and also learn from those speakers and our panelists for those sessions. Thank you once again, and have a good day.